So that's why we need to assess the amount of hypoxemia with pulse oximetry, ABG, and wherever possible, oxygen dissociation curve can also be measured. And we should be able to know alveolar arterial gradient. For calculation of alveolar arterial gradient, we should be able to remember the formula. First, we need to measure what is the alveolar oxygen. Alveolar oxygen level is calculated as FiO2 into atmospheric pressure, which is 760, minus humidity, relative humidity, which is around 47 millimeters of mercury. 760 minus 47 millimeters of mercury will be around 760 minus 47 will be around 512 or 13, and then it has to be subtracted by PCO2 upon respiratory quotient, which is around 0.6. If we remember this formula, we will be able to calculate the alveolar oxygen, and then alveolar minus arterial oxygen, which is derived from ABG, can be calculated, and then AA gradient, if it is more than 20%, that is significant. So if there is increased alveolar arterial gradient, it means there is significant shunt. Okay, and this is how the oxygen dissociation curve is. Oxygen dissociation curve will be shifted to the right and left if there is hypoxemia, respiratory acidosis, or hyperthermia. The oxygen dissociation curve will be shifted to the right, whereas if there is respiratory alkalosis or hypothermia, the oxygen dissociation curve will be shifted to the left. So if the oxygen dissociation curve is shifting to the right side, that is beneficial to the tissues, because here 2,3-diphosphoglycerates will be able to remove oxygen from the hemoglobin and deliver it to the tissues. Whereas if the curve gets shifted to the left side, the 2,3-diphosphoglycerates will not be able to remove oxygen from hemoglobin and will not be able to deliver to the tissue. So that's why we need to correct these causes also: hypoxia, hypothermia, hyperthermia, and fever. These parameters should be corrected, and the oxygen delivery will automatically be corrected. Not only the mechanical factors, but the metabolic parameters also need to be corrected similarly. So we should be able to follow an approach to respiratory failure. If the patient is hypoxemic, we need to see whether the PCO2 is increased or not. If PCO2 is increased, probably it is type 2 respiratory failure. We call it as hypercapnic respiratory failure. Then we need to identify what is the AA gradient, alveolar arterial gradient. If there is significant alveolar arterial gradient, probably there is VQ mismatch. If there is no alveolar arterial gradient, it is only because of hypoventilation. So that is how we should be able to find out the cause of respiratory failure. If the PCO2 is not increased, probably this patient is in hypoxia, which is type 1 respiratory failure. And if this, then we should also be able to calculate the alveolar arterial gradient. If there is increased alveolar arterial gradient, there is shunt, we need to treat that shunt. And if there is no increase in the alveolar arterial gradient, that could be due to high altitude sickness. So these are the investigations which are very pertinent and important to find out the cause of respiratory failure. We should be able to treat the respiratory failure. We need to treat the underlying cause. Oxygen therapy should be advocated to all patients, but it should not happen that we keep on supporting high concentration of oxygen, because oxygen itself is a drug. We have to treat it like a drug, and it has to be titrated below 60% to prevent oxygen toxicity and oxygen related atelectasis. And then if there is muscle fatigue, mechanical ventilation, either non-invasive or invasive form of mechanical ventilation should be provided, and cardiovascular stability should also be provided. And then once the patient is ventilated, primary pathology is corrected, there should be liberation of the patient from the ventilator. So type 1 respiratory failure, the only treatment may be oxygen support, may be sufficient. But if the patient has pulmonary edema, diuretics can be used to reduce pulmonary edema. And then if the patient has pneumonia, the antibiotics and ventilator support can be useful. If the patient has pleural effusion, the pleural effusion has to be drained, and minimize the dead space as far as possible. Type 2 respiratory failure also, support oxygenation, avoid sedation, use bronchodilators. Bronchial secretions can be taken care of by respiratory exercises, postural drainage. If there is pneumothorax, which is a cause of type 2 respiratory failure, it has to be treated immediately because it can be life-threatening, especially if it is tension pneumothorax, needle thoracotomy, or ICD insertion should be there. And if the patient has significant pneumonia, which is causing type 2 respiratory failure, has to be treated. And if the patient is on ventilator support, PEEP or non-invasive ventilation should be given. If the patient has type 3 respiratory failure, okay, due to atelectasis, keep the patient in 45 degrees upright. Abdominal and incision pain control should be taken care of with the good analgesics. Opioid or multimodal analgesia NSAIDs, opioids should be given together, or sometimes epidural anesthesia or regional analgesia with intercostal blockage or local anesthetic agents can be used. Turn the position of the patient every 1 to 2 hourly to prevent atelectasis. Physiotherapy and PEEP on ventilator could be good enough. And if the patient is a smoker and taken for surgery, it has to be stopped 6 weeks before the surgery. Type 4 respiratory failure is due to circulatory shock. We need to treat the cause, like improve the cardiac output, which will correct hypotension. If the patient has low hemoglobin, it has to be corrected with blood and blood products. If the patient is hypoxemic, oxygen support, sepsis should be treated with antibiotics. Fever should be corrected with hypothermic measures. Acidosis should be corrected with ventilator support, or bicarb infusions and electrolyte disturbances can be corrected. If there is muscle weakness, protein, calorie, nutrition can be optimized. As far as the ventilation in ICU is concerned, I would like to touch a little upon the ventilation strategy. How do we put the patient on ventilator? So as I've already discussed, the majority of the types of respiratory failure will need ventilator support. Okay, this is one of the grade 1A indication for any patient who is in respiratory failure should receive ventilator support. So there are two types of ventilator supports. It can be controlled or spontaneous modes of ventilation. Controlled mode of ventilation can be volume targeted or pressure targeted, or both volume and pressure targeted. As we know that volume controlled ventilation, the volume will be controlled, the pressure will keep on changing. Whereas in the patients with the pressure controlled ventilation, the pressure will be kept constant and the tidal volume will be varying. So in patients with the ARDS, what our aim is to keep, especially with type 1 respiratory failure, we need to keep the volume constant. The volume should not vary. If the volume is varying, that will lead to shear and stress injury to the alveoli that can cause volutrauma or biotrauma. Biotrauma means whenever there is change in the volume, or the volume is not kept constant, and when there is shear and stress injury to the alveoli, there will be release of inflammatory mediators that can cause further damage to the adjacent alveoli, and the lungs may get injured again because of this biotrauma. So that's why it is very important that when we ventilate the patient, the volume has to be as low as possible, which is acceptable to maintain oxygenation and to keep the carbon dioxide on check. So the volume targeted ventilation is quite useful in patients with ARDS. Pressure targeted ventilation, where the pressure is kept constant and the volume will keep changing. Pressure control ventilation will be good if the patient is in cardiogenic shock, or any patient with the fluid overload. But no matter whatever the mode of ventilation it may be, unless we judiciously monitor the different parameters that I'm going to talk on my subsequent slide, any mode of ventilation is good enough. But there are a lot of inputs from the physicians all over the world, like why can't we control both volume and pressure, which will prevent injury to the lungs. So that's why pressure regulated volume control mode of ventilation, which will control both tidal volume and control target pressures, will be quite useful. And spontaneous mode of ventilation is IMV with pressure support, or CPAP with pressure support. These are two modes of ventilation where the patient will be breathing spontaneously, and the ventilator will be just assisting if the breaths are not adequate enough. Okay, so this is called as spontaneous mode. And nowadays, this controlled mode of ventilation is no more used. It is assisted control mode of ventilation, where the controlled breaths are given, but when the patient is trying to breathe, those breaths are also supported. So control mode is replaced by assisted control mode of ventilation. So these are the settings on the ventilator when we ventilate the patient. The first parameter, once the patient is hypoxemic with any type of respiratory failure, whether it is type 1 or type 2 respiratory failure, if you have selected control mode of ventilation, we can keep the settings as FiO2 should be 100% as early in the initial phase. If the patient has a tube inside, or endotracheal tube, and we have put the patient on ventilator, the first setting that we choose is FiO2. The FiO2 has to be 100% as far as possible, and we should try to keep it titrating to levels below 60%, where the oxygen toxicity will be avoided. As you know that excessive oxygen can be detrimental. It can cause oxygen toxicity in the form of release of superoxide, which will again target the tissues and cause injury to the tissues. And other form of toxicity is absorption atelectasis, where 100% oxygen, if it is provided, will get diffused out completely through the alveoli, and the alveoli will no more remain open. The alveoli will collapse. So this is called as atelectasis or absorption atelectasis. So that's why in natural air, the content of nitrogen is 78%, which doesn't get diffused out of alveoli and will keep the alveoli open. So that's why our aim is to keep FiO2 as below as 60%, where you will have enough nitrogen also, and you may not have to give excess of PEEP. Okay, because this natural nitrogen itself will keep the alveoli open and will not be completely diffused out of alveoli, and probably the PEEP requirement will also come down. So that's why we may wonder sometimes as to why the air contains nitrogen 78%. It is for this reason the nitrogen is beneficial. If the nitrogen levels come down, or if there is absence of nitrogen in the air, the life will not be possible. Our lungs will collapse completely and it will never get expanded. So this is the natural mechanism. So next parameter that we set on ventilator is tidal volume. The tidal volume has to be 6 to 8 ml per kg predicted body weight. It has to be measured according to the height of the patient, not according to the weight of the patient. Okay, for that we need to remember a formula: 50 plus 0.9 into patient's height minus 152 centimeters for males, and for females it is 45 plus 0.9 into patient's height minus 152 centimeter. So tidal volume should be as low as possible. Several studies have shown that large tidal volume is associated with significant lung injury, volume trauma, and can also cause injury to the lungs. So that's why tidal volume should be 6 to 8 ml. Even for normal lung, even if the lungs are not affected, there is no pneumonia, no ARDS, still the tidal volume has to be as low as 6 to 8 ml per kg, ideal body weight. So PEEP has to be titrated 20 times FiO2. Okay, ARDS net chart, ARDS net chart gives you the values for particular oxygen saturations. Okay, if the FiO2 is 100%, the PEEP can be as high as 20, or if the PEEP is 60, the PEEP can, or if the FiO2 is 60%, the PEEP can be 12. So we need to calculate the FiO2, how much is the FiO2, and accordingly the PEEP should be titrated. So the respiratory rate can be initially 16 to 18 per minute, which will keep that minute ventilation 6 to 8 liters. So if the tidal volume is suppose 400 and respiratory rate is 20, the minute ventilation becomes 8 liters. Okay, 2 into 4, yeah, 8 liters. Okay, so respiratory rate in patients with the COPD, the respiratory rate can be as low as possible in order to give more time for the expiration, so that there is no air trapping or overinflation of the alveoli, and exhalation will lead to complete emptying of the alveoli. So in patients with the COPD, the respiratory rate can be 8 to 12 or 10 to 12. In ARDS patients, the respiratory rate has to be as high as possible. Maximum 35 can be acceptable, because if you increase respiratory rate, the I ratio will get increase, and it will give more time for inspiration, and it is during inspiration this oxygenation gets improved, especially in ARDS patient. So that's why in ARDS inspiratory time has to be prolonged, whereas in COPD patient the expiratory time has to be prolonged. So this is about I ratio and respiratory rate. And alarms, we should also set alarms. What are the limits for alarms? Like peak pressures. If there is high peak pressure, probably the patient has either pneumothorax or bronchospasm, or patient's tube is blocked. So or if the patient has a leak of more than 100 ml. So these leak alarms should be identified in case of any disconnections or a cuff being deflated or any disconnection of the ventilator circuit will lead to leakage, and these alarms should be monitored. If there is such alarm, it has to be addressed immediately, otherwise patients may die because of hypoxemia. So once we have set different parameters on ventilator, right, from tidal volume, PEEP, FiO2, I ratio to the respiratory rate, we should monitor what all we should monitor. We should monitor peak pressure. This is the peak pressure. If the peak pressure is going high above a certain value of more than 30 to 40, it tells you that there is increased airway resistance. The tube may be blocked, or there may be a pneumothorax, or there may be a pulmonary edema. So it has to be addressed immediately. So plateau pressure, second is the plateau pressure. This is the plateau pressure. This is the peak pressure, which measures the resistance of the airway, and this plateau pressure, this distance is a plateau pressure. This plateau pressure measures the compliance of the alveoli, how elastic the alveoli are, or how stiff are the alveoli. If the alveoli are very stiff, the plateau pressure will be high. Okay, if the alveoli are normal or elasticity is maintained, the plateau pressure will be less. The plateau pressure can be less than 30. If it is more than 30, it means the lung compliance is very low. Patient has possibly ARDS, and it has to be treated with either PEEP or recruitment manual. And the second parameter that we monitor is driving pressure, especially in ARDS patient. The plateau pressure minus PEEP will be driving pressure. It has to be less than 17. It has to be monitored. If the plateau pressure is going, if the driving pressure is going more than 17, probably this patient's ARDS is worsening. So the second, third, fourth parameter that we need to monitor is auto PEEP, especially in patients with COPD. There will be some amount of air which is always left inside at the end of expiration, which is not exhaled completely. That will lead to auto PEEP, or we call it as intrinsic PEEP. When we want to measure intrinsic PEEP or auto PEEP, there is a button here we call as expiratory hold button. We give it, we give the expiratory hold for 10 seconds, and we will be able to monitor how much is the auto PEEP. Similarly, for plateau pressure, in volume control, we can measure plateau pressure, but if the patient is on pressure control, whatever the peak inspiratory pressure that we set is the plateau pressure. But when we want to calculate exact plateau pressure, we have to give inspiratory hold for 10 seconds, and that will be able to measure the plateau pressure, and instead it will tell you about the lung compliance. As I already told you, leak has to be monitored, and graphics and loops also should be monitored. Any parameter monitored against time, we call it as scalar graphics, and there are loops also. When one parameter, volume versus pressure, is monitored against each other, will be a loops. That itself is a big discussion, and we can discuss it later in probably in the next lectures about ventilator graphics and loops. So, and then recruitment money is given to those patients who are extremely hypoxemic ARDS patient, and any patient on ventilator, daily X-ray. If there is any change in the oxygen status of the patient, daily X-ray is mandatory. Otherwise, if there is no change, X-rays can be done as and when required. And daily ABG should be done to assess the oxygenation status, ventilation status in the form of carbon dioxide levels should be monitored daily. So once the patient is put on ventilator, there should be attempt on our side, willingness from our side to wean them from ventilator. We have to remove them from ventilator, and for that we need to see that the patient is fulfilling weaning criteria. The weaning will be initiated only when the patient is ready to breathe, or the primary pathology for which the patient is being ventilated is under control by more than 50%. Then we can start weaning the patient from control mode to a spontaneous mode of ventilation. And then we should also be making sure that the patient is hemodynamically stable, his blood pressure is normal, his oxygen levels are normal, his respiratory rate is normal, he is not anxious, he is not agitated, he is fully conscious, awake, alert, he has good tone power reflexes, his cough reflex is good, and he doesn't have excessive secretion. These are the conditions where we can start weaning the patient from ventilator. So that is how I would like to conclude my session with the thought process that, like, we need to have a better understanding of respiratory failure. We need to identify what type of respiratory failure it is, whether it is type 1 respiratory failure due to hypoxemia or lung pathology like ARDS, pulmonary edema, And type 2 respiratory failure is purely because of muscle weakness. Okay, respiratory muscle weakness, which leads to CO2 retention. And type 3 respiratory failure is due to atelectasis. Okay, where the lung parenchyma is not contributing, or the alveoli are getting collapsed. Okay, it is not taking part in oxygenation, and we call it as atelectasis. And fourth type of respiratory failure is circulatory failure. We need to treat the circulatory failure with improvement of cardiac output and improve the oxygen delivery. And then ventilators has to be ventilator support has to be instituted as and when required. Their patient should be able to fulfill the criteria: extremely hypoxemic patient, severe respiratory failure, and patients who have undergone surgery and are under the effect of sedation or paralysis. These are the patients who will receive ventilator support. We need to set the ventilator settings properly and try to get FiO2 as low as possible, PEEP as low as possible, and tidal volume has to be in check with 6 to 8 ml per kg ideal body weight. And we should have willingness to wean the patient from ventilator, because if we don't wean the patient from ventilator, patient may become ventilator dependent, and ventilator related complications can happen. And infections, pneumonia, ventilator induced pneumonia, ventilator associated infections can also contribute to patients' delayed recovery from the support, and patient's stay in the hospital will get prolonged. And in the bargain, the cost associated with the treatment also will go high. Sorry, the cost of the treatment also get very high if the patient remains on ventilator for a long time. So we should be ready if the patient is treated adequately. And that is how I must say thank you all.